This is Dr. A with another Clean Chem review video. We're going to look at thyroid function assessment. Alright, so let's look at all the different thyroid function tests. So most of these tests are going to be run on serum or heparinized plasma, depending on the labs and the specimen requirements. So they're blood tests. TSH is the most useful of all the thyroid function tests. It is the most sensitive indicator of thyroid dysfunction. A lot of times it's run by immunoassay. A high TSH with a low total T3 or low free T3 or free T4 will indicate primary hypothyroidism due to thyroid gland dysfunction. For example, Hashimoto's thyroiditis is quite common. So the thyroid gland itself is what's not working, and that's why there's high TSH, because the pituitary is working adequately and it's trying to stimulate the thyroid gland to function, and that's why you have high TSH. Okay, but if you have high TSH and also have a high total T3 or high free T3 or free T4, then you're looking at a secondary or tertiary hyperthyroidism, so we're also known as a central hyperthyroidism. So it could be that there's a pituitary tumor or something that's creating a lot of TSH, and then that TSH is doing its job and making the thyroid crank out a bunch of T3 and T4, and leading to hyperthyroidism because there's too much T3 and T4 out into the bloodstream, so you get all the signs and symptoms of hyperthyroidism. Okay, so then if you have a low TSH and a high total T3 or high free T3 or free T4, then you would be in primary hyperthyroidism. So again, your thyroid itself is overproducing the thyroid hormones and not at the direction of the pituitary, which is why the pituitary turns down the production of the TSH, because it senses that there's already too much thyroid hormone, and so it's like, no, we don't need to make TSH because there's already too much thyroid hormone. So your TSH levels can be just about non-existent also in this kind of cases. Common cases for this profile would be Graves' disease or thyrotoxicosis. If you have low TSH with a low total T3 or a low free T3 or free T4, again, you would be in secondary or tertiary hypothyroidism or central hypothyroidism, where the pituitary or the hypothalamus is failing to produce either TRH or TSH. TSH can be low also if a patient is on too much thyroid medication, or TSH can be high if the thyroid medication dose is too low, or the patient is not on enough thyroid medication. So quite a bit here too. So let's look at serum total T3 and T4. So they're generally measured by radioimmunoassay, immunoassays, high performance liquid chromatography, or chemiluminescent assays. It's worth to note that more than 99.9% then of thyroid hormone is bound to protein, and so if alterations in your thyroid hormone binding proteins can frequently lead to total T3 or total T4 levels that are outside of normal range, but it doesn't represent true clinical thyroid dysfunction. It may actually simply represent that there's not enough of the thyroid binding globulins or albumin or whatever to be around. So it's usually better to assess thyroid function when the patient is not severely ill and there's adequate production of all the proteins that the body requires. T3, total T3 and T4, although total T4 is hardly ever done anymore. These are ordered when the TSH is abnormal or the patient is experiencing symptoms indicative of hypo or hyperthyroidism, and the TSH might still be normal or borderline normal. The results are interpreted with the TSH results, but as a general rule, high levels indicate of T3 or T4 would indicate hyperthyroidism, and low levels would indicate hypothyroidism. And of course, then you can do free T3 and free T4. They're similar to the total T3 and T4, but obviously they're not protein bound, they're free. And so also because there's so little of it, it's going to be read in, like, I believe, nanograms per deciliter. Similar interpretation of results, right? Too much free T3, free T4 would be hyperthyroid, not enough free T3, free T4 would be hypothyroid. Again, ordered with a TSH and a total T3 to help interpret what's going on with thyroid function. And these can also be used to monitor patients with known thyroid disorders. And then there's also the reverse T3. So this one is not often done by physicians, but when the body is under stress, it can convert the free T3, the active thyroid hormone, to reverse T3 as a way to slow down metabolism. It's also often referred to as the brakes of thyroid function, and is often seen with high cortisol, which of course is linked to stress. Then you can do thyroglobulin levels. It's prohormone, so remember you need thyroglobulin to build T3 and T4. And if it is in the circulation, it's usually proof of the presence of thyroid tissue or destruction of thyroid tissue problem. And so thyroglobulin is an ideal tumor marker for thyroid cancer post-treatment surveillance. Thyroid antibodies can also be ordered. So you can have antibodies to the thyroid receptor, which would be common in Graves' disease, or to either thyroglobulin or thyroid peroxidase, or both, for Hashimoto's thyroiditis. So these are both autoimmune thyroid disorders, and these thyroid antibodies would be used to obviously test for these autoimmune thyroid disorders. So we can also do nuclear medicine evaluation. There's the radioactive iodine test. It is used to assess metabolic activity of the thyroid, and yes, the patient is injected with with iodine that's radioactive, and when it's given orally, a percentage of the radioactive iodine dose is taken up by the thyroid gland. And this can be used to evaluate and treat thyroid cancers. A high uptake of that radioactive iodine would suggest high metabolic activity of the thyroid, while a low uptake of the iodine would suggest metabolic inactivity. Because TSH stimulates iodine uptake, also then TSH levels must be taken into account when you do this radioactive iodine test. And then some other tests. Thyroid ultrasound is a medical imaging test or technique. The ultrasounds have gotten so good now that they are capable of detecting thyroid nodules of exceptionally small sizes, less than 1 centimeter. That's less than ½ an inch, right? And then also fine needle aspiration, that would be like a biopsy. It's often the first step and the most accurate tool to evaluate thyroid nodules. In routine use allows prompt identification and treatment of malignancies and avoids unnecessary surgeries if the case is benign. A small gauge needle is inserted into the nodule, and the cells are aspirated and then, of course, stained and evaluated by a pathologist. And that is it. Thank you so much.